Hello everybody, welcome. It's lovely to see you all and thank you for joining today's event, which is hosted by ASH and by the Smoking and Pregnancy Challenge Group. I'm delighted to be chairing this event, and it's wonderful that we've got almost 400 people from across the country registered. I think this makes it one of the most heavily subscribed Challenge Group events ever. So it also shows there's a lot of enthusiasm for getting this agenda back on track, which is so important, and for supporting women and families to have a healthy and smoke-free pregnancy. So I hope everybody has had a copy of the agenda and that's been sent through. And at the end of the agenda, you will find the links to join the regional breakout sessions. If you haven't had a copy or you've got any other issues, please just email admin@smokefreeaction.org.uk. Now, I think maybe we can put that email address in the chat box so that you've got it there as well, so that you've got the links for the breakout sessions if you haven't got them. And then there are one or two housekeeping points that I'm just going to kind of run through before we get going on the exciting set of different talks and presentations that we've got coming up. So the meeting is being recorded, and that means that the recording will be available on the ASH and the Challenge Group web pages after the event. And the way that we're running this is that all of the panelists will keep themselves muted and have their webcams off unless they're presenting. And as it says on the slide here, the ASH staff will mute anyone who's unmuted and not presenting, just to make sure that you're not distracted and that you can hear everything very clearly. We've made a decision, sadly, that we don't have time for a Q&A session. It's really packed, the amount of information that we've got this morning, and all really important. But clearly, it is also very important that you ask questions if you want to. So the way around that is if you submit all of your questions into the question box, then the amazing colleagues from ASH will collect all of those questions, provide answers, and then put it into a document that will be shared following the event. So please do ask the questions, and even if they're not answered straight away today, you will get the answer sent to you. So moving on to explain who is hosting the event. It's ASH, the Action on Smoking and Health, which is public health charity that's working to eliminate the harm caused by tobacco, and their wonderful staff are leading on this. It's also being hosted by the Smoking in Pregnancy Challenge Group, which is a coalition of organisations, and the group was initially got together in 2012 by ASH and the Lullaby Trust, another baby loss charity, following a challenge from the then Public Health Minister to produce recommendations on how the government's smoking in pregnancy ambitions could be realised. And I'm lucky enough to jointly chair this challenge group, along with Professor Linda Bould, who you will be hearing from later, from the Spectrum Research Consortium and from the University of Edinburgh. So the focus of, these are the range of people who make up the challenge group, and you can see lots of royal colleges, charities, lots of different organisations coming together, recognising the importance of reducing smoking in pregnancy and supporting mothers to quit. So I don't have to tell all of you the impact that the smoking has on pregnant women and its effect on stillbirth, miscarriage, sudden infant death, and also the effect of secondhand smoke. And that's really why we're all here. And obviously, from my perspective, from SAN's perspective, smoking is an incredibly important issue, as it is for all of the other organisations in the challenge group. But Also important to note that exposure to secondhand smoke during childhood increases a risk of other things as well, not just SIDS, but chest infections, asthma, meningitis. It is so important to be addressing this issue, and it's just wonderful that so many of you feel that it's important enough to attend today. So thank you. And then the only other thing that I just wanted to flag up here is, again, I'm sure you all know this, the current tobacco control plan for England has got this target for reducing smoking at the time of delivery, SATOD, to less than 6% by 2022. And you can see on this graph that actually at 1922, we were only at 10.4%. So there is a lot more to do if we're going to get back on track. The long-term plan, the NHS long-term plan, has a clear commitment there to support a pathway for pregnant mothers to have a smoke-free pregnancy. But it's vital that every single NHS trust commits to the Saving Babies' Lives care bundle if we're to maximise the impact of this commitment. We know these are challenging times. We know that COVID's exacerbated health inequalities. We know that there's an additional burden on those poorer communities that are more at risk of infant mortality and have higher smoking rates. So it makes it a really important issue, but also a really important time to be thinking about this. So I'm delighted to welcome the first of our speakers. I'm going to hand over to Professor Viv Bennett, Chief Nurse and Director of Maternity and Early Years at Public Health England, and she's going to talk about the importance of working across the whole system to tackle maternity smoking. Thank you, Viv.
Thank you very much. Delighted to be here today, together with Jackie Dunkley-Bent, the Chief Midwifery Officer. We are together the clinical champions for this programme, so it's brilliant to be here today. I'm going to say some of the same things that have just been said. That's how important it is, and hopefully give you a little bit more information as well. I think before starting though, I say, as you all know, people at the front line know, this has been a really tough time to have a baby. People have not been able to have a partner with them in some antenatal contacts. They've not had necessarily the birthing that they wanted to have. They've not had the kind of postnatal support that in this case is, you know, needed to help transition to life with a baby, and we do know that's a period where people may resume smoking, having managed to stop during a pregnancy, and they've not had the support of family, friends, and an opportunity to socialise. So it's been a really tough time. It's been tough for a lot of people, and particularly people who were already in very difficult circumstances. So it is really important that we get all of our work to support people preconceptually, in pregnancy, and when they have their babies, back on track after COVID, and start to reinvigorate our ambitions around this and to drive forward with the progress. You've already seen this slide. Have another look, because it really makes some quite shocking reading, and it really sets the scene for our work today. Moving on, please. And again, Clea's shown us the kind of trajectories. I think there's one more recent figure at the bottom there, which is the latest we have. The SATOD data at Q1 to 3 2021 is now 9.8%. So down, but not down enough. Next one, please. Next slide, please. Thank you. So what's no, sorry, the one before. Thank you. So what's happening now at a kind of population level and at a policy level? So in terms of the tobacco control plan, we know that the development of a new tobacco control plan is due by this summer. which is a really important thing, to have that continued focus on this really important area for the public's health. Public Health England and its successor bodies will continue to work with the Department of Health and Social Care, and indeed across government, to engage with stakeholders to move towards smoke-free 2030. And a lot of high-level ministerial governmental interest in tackling health inequalities, particularly in the recovery from COVID, and particularly, I think, increased understanding that tackling those inequalities and moving to preventative approaches means starting very early in life, including in pregnancy, and including, obviously, our focus today, smoking in pregnancy. People are looking at many forms of behavioural science to how that at an individual level we can help women, families to stop smoking pre and during pregnancy and then forever, including what incentives might look like, and further NICE guidance is being developed, which will also be due this summer. Next one, please. For smoking and pregnancy supporting the long-term plan, some specific inputs are listed here. Being able to access stop smoking advice and nicotine replacement therapy from maternity teams will be really important. Learning from early implementer sites, and the one listed here is the Greater Manchester pilot, and plans to roll that out over a period of a couple of years. I've already mentioned the incentive idea and how we can support fathers and families to support mothers to stop smoking, and regional posts to help the rollout as we move to a new health system, and the importance of a public health and health system that's joined up at integrated care system level. It's vital that we offer that support and expertise. Next slide, please. We've developed a number of specific resources which take a population approach to what can we do to create a smoke-free environment that actually makes it much easier for people to stop smoking, and be supported by behavioural interventions to do that. And some of them are listed down here. I only had 5 minutes. I think that's my 5 minutes. I hope that's done a bit more scene setting, and I hope you have a great conference for the rest of the morning. Thank you.
Thank you so much, Viv. That was brilliant, and it absolutely was within the 5 minutes. So thank you. Really, really good start to the session. So I'm next going to introduce John Waldron, who's the Senior Policy and Public Affairs Officer at ASH, and he's going to set out the findings from the report, Getting Back on Track, Delivering a Smoke-Free Start for Every Child. So John, over to you.
Thank you, Clea. Hopefully, can you see my screen?
Yes.
Perfect. Let me just minimize that. Great, okay. Can you see the full screen one or the one we've noticed?
And we can actually see the presenter.
Okay, let me swap that.
So
there we go. Is that better?
Yeah, that's perfect. Okay, thank you.
Perfect. Hi, everyone. I'm just going to quickly run through some of the key findings and recommendations from the report Clea mentioned, Getting Back on Track, Delivering a Smoke-Free Start for Every Child. And I'm also going to give a quick overview of some of the resources developed by the challenge group and kind of where you can access those. So the purpose of the report was to understand why national smoking and pregnancy or SATOD rates have only declined quite marginally since 2015, despite that government ambition to reduce SATOD to 6% by 2022. And then also to set out recommendations to inform the next tobacco control plan, maximise the impact of the NHS long-term plan, and get us on track to achieve the government's smoke-free 2030 ambition. Now, the report sets out 22 recommendations for achieving, across a number of areas, so achieving the smoke-free 2030 ambition, overcoming variation, and a number of others, and these apply to national and local government, PHE, or what comes after it, NHS organisations, Royal Colleges, and other stakeholders. So quite rightly, we talk a lot about the health implications of smoking in pregnancy, and we've seen that table showing the kind of the risk ratios for smoking in pregnancy. However, as well as a number of tragic human costs, smoking during pregnancy also presents significant financial costs to the NHS, with pregnant smokers requiring more care and placing additional costs on trusts compared to non-smoking women. And the Royal College of Physicians estimated that maternal smoking cost the NHS over £20 million in 2015-16, and this is reinforced by audits from NHS trusts. So an audit conducted by Barnsley found that 10 women who smoked cost the maternity unit approximately £46,000 compared to £13,000 for 10 non-smoking women. Similarly, at Poole, smoking pregnant women cost the trust an extra £737 extra per patient compared to non-smokers. So really significant costs to the NHS there. And as most of you probably know, rates of smoking in pregnancy have a strong social and age gradient, with poorer and younger women much more likely to smoke and be exposed to secondhand smoke during pregnancy. They're less likely to quit and more likely to relapse to smoking after birth. And you can see here that women in the most deprived decile, so they're on the left, are over 5 times more likely to be smokers during early pregnancy, so at bucking, than those in the least deprived. And you can see a similar trend for age, with younger women much more likely to smoke during early pregnancy than older women, and high rates of smoking among younger, more deprived women correspond with significantly higher rates of infant mortality than the general population. So there's lots of national strategies related to tackling smoking in pregnancy, and I'm just going to touch on them very briefly. So you've got that tobacco control plan, which has already been mentioned, which sets that 6% target by 2022. The Prevention Green Paper, published in 2019, set the ambition of making England smoke-free by 2030. And of course, that includes pregnant women, their partners, households, family members, and so on. So we still have a long way to go to get there. You got the Maternity Transformation Programme, which includes the Saving Babies Lives Care Bundle, and then the NHS Long-Term Plan, which commits to delivering that opt-out smoke-free pregnancy pathway for expectant mothers and their partners. And we're going to talk about that later on. So meeting that 6% target would also contribute to the national ambition to halve stillbirth and neonatal mortality by 2025. So you can see on this graph here, the yellow line shows the stillbirth rate since 2010 and the rate of decline needed to halve stillbirths by 2025, and the blue line shows the same for neonatal death. So although encouraging progress has been made in reducing stillbirth rates since 2010, neonatal mortality has kind of dipped and crept up again, effectively flatlining during this period. And we estimate that securing the government ambition to reduce smoking in pregnancy to 6% would contribute between 8 and 13% of the reductions in stillbirths needed to meet that target, and between 2 and 5% of the reductions in neonatal deaths, which is quite a significant contribution to achieving these ambitions. So the big question, why aren't national SATOD rates falling fast enough? So there's lots of contributing factors, as you would imagine. There's significant regional and local variation in service delivery and outcomes in the NHS and in stop smoking services. The number of pregnant smokers accessing stop smoking services has declined by 1/5 since 2015. And in the same period, the number of adults in general accessing stop smoking services has almost halved. And it's quite simple, less people coming through the door equals less people quitting. The public health grant for local authorities has also been cut by 1/5 since 2015, which has resulted in less funding for smoking cessation. Most areas have managed to retain some level of support for pregnant women, but cuts inevitably restrict how much support stop smoking services can provide. And then the constantly changing local service offer really makes it hard for maternity staff to refer pregnant women to support and then to follow up on that support and what the outcomes have been, because they don't know what offer is available from one year to the next in their area. And then finally, smoking in pregnancy remains concentrated in younger, more disadvantaged groups who need enhanced support to quit and aren't really getting that at the level required at the moment. And collectively, these really highlight a broader need to increase the numbers of women who quit smoking before they become pregnant, increase the number who quit during pregnancy, and then increase the number who are supported to stay smoke-free once their baby is born. So although Nationally, SATOD rates have declined fairly marginally since 2015. Regionally, we see a lot more variation, with some areas going much further and faster than others, kind of as you can see here. So this shows the regional change in SATOD rates since 2015. And it's clear that many of the areas that have seen really sustained declines in SATOD rates are those with coordinated regional and local strategies. This isn't just happening by accident. And we're going to hear from Jane Coyne in Greater Manchester about some of the really impressive work they've done a little bit later on. This regional and local activity really does need to be backed up by a comprehensive national strategy to tackle maternal smoking and smoking in the wider population. And this is something that both ASH and the Challenge Group are advocating for in the next tobacco control plan, and I'll come on to this later. But right now we have a big opportunity through the rollout of the NHS long-term plan to really develop more coordinated local and regional approaches and kind of address some of the variation we're seeing in local service delivery. And you can see here that that regional variation is replicated at a local level. So this shows the change in SATOD rates for NHS CCGs since 2015. And you can see that while almost half of CCGs have achieved declines in smoking in pregnancy rates of 1 percentage point or more, in a fifth of CCGs, so those ones on the right, SATOD has actually increased by 1 percentage point or more. And the effect this has on the national figures is to kind of cancel out a lot of that progress made, and it helps to explain why the national declines look so small and why you get that flatlining effect. And this visual is really useful for showing where we need to target our efforts to improve the quality and consistency of services to get those rates moving in the right direction. And it also shows us that it's not an impossible task. Lots of places are doing this and are seeing big declines. We just need to see that progress happening across the whole system, and it absolutely is possible. So how effective is the system at kind of connecting women with stop smoking services? So of women in England who were smokers at their booking appointment in 2018-19, 16.5% went on to set a quit date with local authority stop smoking services. And this varies substantially across regions. And we know that once women actually engage with stop smoking services, many of them will go on to quit. But as that 16.5% figure shows, just getting women through the door is a big part of the challenge. And just increasing that number would have a really significant impact on the numbers that then go on to quit. And of course, the long-term plan will have a really positive impact here by providing stop smoking support directly through the NHS. But local authorities will remain a big part of the picture, and the long-term plan isn't going to fix referral pathways that aren't working as well as they could. So NHS trusts and local authorities really need to be strengthening those referral pathways now to ensure that once the long-term plan is rolled out, they're kind of getting the most bang for their buck. So the report also incorporated the results from a survey of specialist stop smoking in pregnancy support provided by NHS trusts and local authorities that was conducted by ASH. So this, we had 95 NHS trusts and 99 local authorities responded to the survey. And I just want to highlight some of the key results here. So 43% of NHS trusts that responded commissioned specialist stop smoking support for pregnant women. And of these trusts, 2/3 co-funded that support with local authorities. A third reported not having a budget for NRT and almost also nicotine replacement therapy. And almost half were unable to say how many women set a quit date after receiving support from the trust, primarily because that data wasn't readily available. And when asked to name the software they used to record quits, every single answer was different, with trusts using a mixture of local systems, Excel spreadsheets, bespoke systems, and patient care notes. There wasn't any consistency. And I think these findings are interesting because they illustrate some of the challenges that will arise as the smoking in pregnancy components of the long-term plan are rolled out, particularly around data and data collection, where trusts are going to need to be able to evidence the outcomes from the support they commission. And from what we found at the moment, that is proving quite challenging. So I just want to highlight 3 of the recommendations which kind of focus on improving service delivery in trusts. So the first one is priority should be given to reinstating element 1 of the Saving Babies' Lives Care bundle as we emerge from the pandemic. This one has already been flagged and is kind of the most obvious one, I think. So the pandemic has been hugely disruptive, but as we recover, we need to get back on track with delivering element 1. the care bundle has been really effective for getting smoking in pregnancy kind of on the agenda in the NHS and driving improvement in service delivery, and we want to see that continue. And this needs to happen ahead of the long-term plan rollout. The long-term plan isn't there to help people implement the care bundle. It should have already happened. Secondly, every trust should have a named person to be responsible for the delivery of smoke-free pregnancies. So ideally, this would be a smoking cessation midwife, which many trusts have, but really it can be anyone leading on this work locally who is able to engage with senior leadership in the trust. And activities within this role can include ensuring training is available, providing support and performance management, and engaging with external stop smoking services. And this role should also involve advocating for more investment and prioritisation of work to tackle smoking in pregnancy locally in the trust or the LMS or the ICS. And LMSs also need to ensure that there's a system-wide pathway to support women and their partners and communities before, during and after pregnancy. And this has already been kind of mentioned. We know nearly half of women who quit smoking during pregnancy relapse postpartum, and that those who live with smokers are more likely to smoke and find it hard to quit. And addressing this means working closely with health visiting services and other professional groups such as children's services or sexual health services to ensure that women and their partners have access to stop smoking support pre and postnatally. And one of the key benefits of this is to ensure that women don't go into their second or third pregnancy as smokers. So the report also includes a number of national recommendations, which Ash and the Challenge Group will be kind of calling for and advocating for over the next few months and years. So firstly, implement the recommendations set out in the Roadmap to a Smoke-Free 2030. And I won't get into the detail of this, but the recommendations in this roadmap are really about reducing smoking rates among the wider population, so specifically the most disadvantaged communities with the highest rates of smoking. And these are relevant because reducing smoking rates among younger, poorer smokers before they become pregnant is really central to reducing rates of smoking in pregnancy. Secondly, we want to see a new target for reducing SATOD rates to get us on track to reach a smoke-free 2030. So the next tobacco control plan should really aim to reduce SATOD to 4% by 2026, which will put us on track to deliver a smoke-free start for every child by 2030. And the other recommendations address improving the provision of training to health professionals, which is obviously a big issue, developing interventions to reduce relapse to smoking postnatally and smoking among dads and partners, and then also introducing financial incentives more widely to support pregnant women to quit. So now I'm just going to quickly skim over some of the resources offered by the Challenge Group and where you can access them. So we've produced a number of 4 national strategy reports, which you can see here, kind of reviewing the current policy context and making recommendations for the future. We've got a number of briefings, which hopefully many of you have seen. So these are evidence into practice briefings, kind of setting out that evidence and lessons for practice for commissioners. So the latest one covered CO monitoring and data collection. We have others on incentive schemes and engaging partners. And we also have produced annual briefings for local maternity systems, which include local data, case studies, and other updates. We have a number of training materials, including a report on maternity workforce training, and then links to training resources from the NCSCT, e-learning for health, and so on. Hopefully you've all seen these. We have lots of resources for professionals to use with women and families. So they're on CO monitoring, smoke-free homes, and e-cigarettes in pregnancy. And we also coordinate a network of smoke-free pregnancy champions, with the aim being to have one in every NHS trust. And so this is just an opportunity to receive tailored information and resources, feed into national discussions, and kind of share best practice and ask questions of other colleagues. And if you want to join this network, you can just email me, and my email is in one of the next slides. And you can access all of this just on the Challenge Group website. So just search Smoking in Pregnancy Challenge Group, and you can see they're broken down by topic, so it's nice and easy to navigate. That's it from me, and there's my email address. Thank you very much. I hope that was helpful.
Thank you very much indeed, John. That was really, really good. Lots of context and hopefully lots of links for people to follow as well. Thank you. So we're now going to move on, and I'm going to introduce Martyn Willmore, who's the Tobacco Control Senior Programme Manager at PHE, and he's going to talk about the reintroduction of CO monitoring. Thank you, Martyn.
Thanks, Clea. I'm just looking to share my screen at the moment, which is always a struggle on this. John, can you share my slides? Is that possible for you to do that?
Yeah, of course. 1 second.
Thank you. So while John's setting those up, and apologies I couldn't figure it out. Yeah, as Clea says, I work for Public Health England as part of their National Tobacco Control team, and fully endorse what John's just said there about some of the opportunities to do further work to tackle smoking at time of delivery rates. But that's not what I'm here to talk to you about today. Going to focus on getting back better through, or building back better through the introduction of CO or carbon monoxide monitoring. So clearly this is an area that's taken.
Okay, sorry, can you see that? Is that full screen?
I can see it fine, thank you.
Perfect.
So I'm going to talk about CO monitoring, but very conscious that that's been disrupted both in terms of stop smoking service delivery, where where CO monitoring has been used predominantly to validate quit successes or to monitor progress, but also looking at, particularly today, looking at the way that we use CO monitors in pregnancy to identify potential smokers at time of booking and to get them on a referral pathway into behavioural support. Next slide, please, John. So a few acknowledgements up front. As Viv's already mentioned, it's been a difficult year for parents and mums to give birth. It's also fair to say it's been a really difficult year for midwifery staff too over the last year with the challenges of COVID, but also I know the professions kind of felt under pressure from all sides. So so the work that we've been able to do to kind of keep smoking up the agenda has been fantastic. And already mentioned, it's been a significant disruptive year from COVID in terms of stop smoking service provision. And again, the services have done a fantastic job in being able to continue delivering that life-saving support remotely for much of the last year. And all that disruption has been going on at a time when we were hoping to roll out the commitments within the NHS long-term plan, certainly around the early implementer sites. But again, as already been mentioned, there's been some delay to that implementation, but it's really positive that that's starting to roll out right now, and I'm sure we'll hear more and discuss more about that later on this morning. So set against that backdrop, it's really impressive that SATOD rates have fallen over the last 12 years to below 10% for the first time, and even more surprising that the number of pregnant smokers accessing stop smoking service support to quit has gone up significantly over the last 12 months. So that's testament to all the great work that many different partners have done to keep smoking in pregnancy so high on the agenda. So I'm going to use the word we a lot in terms of the next few slides and the work that we've done over the last year, but that's the Royal Week. I'm talking about work that we've done alongside colleagues in NHS England, the Health Protection Agency, MHRA, and many colleagues indeed that are on this panel today. Thanks, John. So in order just to kind of bring us up to date with where we are now, I think it's important just to go briefly back to the start in terms of where the issues around CO monitoring and COVID began. So back in March 2020, as a number of cases spread across England, it's fair to say that on a daily basis I was getting as many as a dozen queries about whether stop smoking services should continue to deliver behavioural support face-to-face, and indeed whether they should continue to CO monitor their clients. And it's important to remember back at that time we had relatively little information in terms of how COVID was transmitted. We certainly had next to no information on the relative safety or otherwise of CO monitoring set against that backdrop of the pandemic. So government guidance 14 months ago fairly quickly kind of coalesced around recommending that public health services such as stop smoking services should be delivered remotely where possible, and also the NHS quickly also issued similar guidance that non-urgent antenatal appointments should be done remotely where possible. So fewer services were seeing clients directly face-to-face, and set against that backdrop, it was a relatively easy decision at that point to recommend that we should pause CO monitoring both for stop smoking services and within maternity at that time. But it's important, I think, to emphasise that wasn't because we'd identified a specific risk with CO monitoring. It was set against the backdrop of national guidance, what the recommendations were, to give us a little bit of time to understand what the issues might be and what the level of risk might be as well. Next slide, please, John. So given, as has already been mentioned, CO monitoring was embedded within Saving Babies' Lives Care Bundle, and that many of us had spent 10, 20 years trying to embed CO monitoring as part of routine antenatal care, it was important that we fairly quickly investigated how safe it was to resume CO monitoring and what risks might be associated with that. So we wanted to look at the risks of transmitting COVID by clients breathing into the same monitor, or by handling the monitor and passing it back to the healthcare professional. We also wanted to look at things like viral filtration efficacy standards, more about which on the next slide or two. We certainly need to look at things like infection prevention and control protocols around all of this, and working with various agencies to understand the risk. And the last point I want to make on this slide, it would have been the easiest decision in the world at that point to say that we're going to pause CO monitoring for the duration of the pandemic. It would have probably saved me a few grey hairs if we'd done that. But we had to weigh that up against the fact that why is CO monitoring so important in the first place? Why is it recommended by NICE? Why is it part of the care bundle? It's because we know that CO monitoring identifies women who smoke at booking. It helps to facilitate a really good quality referral into stop smoking support, and ultimately it helps to save babies' lives. So we couldn't just decide to pull the plug on CO monitoring indefinitely. Next slide, please. So viral filtration efficacy, or VFE for short. I won't profess to be an expert on this, but fortunately we were able to speak to the people that were experts on it, and that at the time was those that previously worked under the Health Protection Agency that had undertaken testing of carbon monoxide monitors back in 2017 to assess how effective they were in filtering out potential bacteria, and in this case viruses. So one of the questions that we've had a few times is, if that testing was done in 2017, it couldn't have been tested against the coronavirus, because that wasn't around then or wasn't known then. And that's true, but it's standard protocol that we don't test, or that Health Protection Authority don't test filters against live viruses anyway. What they do is they create a virus cocktail, if you will, and they expose filters from, whether it be CO monitors or any other product that's on the market that has filters built into them. They test that cocktail against the filters. I think the key consideration here in terms of that testing is the size of the viral particles that are used as part of that testing protocol. So the viral cocktail uses virus particles that are 24 nanometers in size. That may not mean too much to me or to anybody else out there, but the key consideration is that the COVID particles are 5 times larger than that. So in effect, because they're larger, COVID particles are larger, they're more likely to be caught by the filters within the CO monitors. So all the results that were reported by the Health Protection Agency are likely to be a significant underestimate of how effective CO filters are at catching that COVID-19. So having said that, the test results showed that with single-use monitors or mouthpieces or D-pieces, mouthpieces, or where the filters were built into, single-use filters were effective in 99.8%, if not higher, of all cases in filtering out the viral cocktail. It's also important to flag up that Bedfont Intermedical have a filter that's built into the D piece, which is replaced every 30 days, so isn't single use. And when 30-day use of that D piece was simulated under a humidifying rig, the results achieved there for viral filtration efficacy were over 97%. And again, that just, I think, was still a good figure to be achieved. It kind of shows the importance of cleaning the CO monitor in between individual users, but also the importance of replacing those consumable parts on a regular basis in line with manufacturer's guidance. Interestingly, we discovered there is no national minimum standard for CO monitoring viral filtration efficacy. So that wasn't all that helpful, but what was clear is that both of the major manufacturers of CO monitors on the UK market were following or ISO quality standards, and they had responded to the specific risks of COVID-19 and had produced further guidance for handling and cleaning their machines during the course of the pandemic. Next slide, please, John. So just a couple more slides to go. So having looked at the testing, we also spoke with infection prevention and control colleagues to discuss specific requirements around potential resumption of CO monitoring. And they advised that they defined CO monitoring as a non-aerosol generating procedure, because while it does obviously involve breathing out, it's not a sharp and prolonged expulsion of breath, so it's not aerosol generating in their terms. So that meant that the process should fall under a fairly standard set of IPC guidelines, which essentially means that it should only happen where professionals can maintain a 2-meter distance between themselves and the clients that they're testing. Any CO monitoring should be done in a well-ventilated environment or room, and that a standard set of PPE could be used. And interestingly, I think that's a standard set of guidance that would apply even to just having a consultation with a healthcare professional. If you're seeing a healthcare professional face to face, you should be following those protocols. So the CO monitoring aspect doesn't particularly add an additionality of risk in terms of that IPC guidance. Next slide, please, John. So based on all that, and that's the role we developed guidance, which we submitted to the National COVID Guidance Cell back in October last year, and that recommended that CO monitoring could be resumed if all those necessary protocols and guidance was followed. And the incident director signed that off in mid-October last year. PHE communicated that decision to stop smoking services predominantly through the NCSCT, and I know that colleagues in NHS England communicated that through a maternity transformation bulletin back in November. Albeit a couple of weeks after that guidance, we were able to get published with eLearning for Health, a new training module on how to resume CO monitoring safely. And thanks to Hilary Waring, particularly, and others for managing to turn that around and working with us so quickly on that. And the link to that online free training guidance is there. Last slide, please, John. So all that being said, we as PHE and NHS England have issued guidance on how CO monitoring can be resumed safely, and that is supported by the evidence. However, it's not within PHE's gift to mandate that all CO monitoring should resume. We've I think hopefully now clearly expressed any resumption should be subject to local risk assessment. It's a decision based upon circumstances locally around things like ventilation, size of rooms, and issues such as that around maternity. And we've been really keen to work with the Royal College of Midwives around producing further guidance for that, and I know they've got some guidance on their websites. We've continued to receive a number of queries over the last 6 months since this guidance has been issued. Queries about what happens if the number of cases rises locally, what happens if new COVID variants are identified. And I understand that these are all valid questions and all very valid concerns, but they don't fundamentally change our guidance around the safe resumption of CO monitoring, where all the IPC guidelines can be followed and where we're following the manufacturer's guidance on how to handle products safely. So we continue to keep all the national guidance under review from places like the IPC and from the government, and we will update guidance further as and when we're starting to get queries now about whether we can relax some of those measures, and equally, we wouldn't be doing that independently around CO monitoring and maternity. We'll wait to see what the national measures are. Anecdotally, we hear that orders for CO monitors have been going up nationally, which is positive, and certainly get feedback from places that have been able to instigate this. And as John pointed out in the previous slide, said this is a key fundamental building block in terms of delivering Saving Babies' Lives Care Bundle and moving on to the NHS long-term plan. So thank you for your patience, and I'm happy to take any questions after the event. Thank you.
Thank you very much indeed, Martyn. Really helpful and very clear. So moving now on to Professor Linda Bald, who's my co-chair for the Smoking and Pregnancy Challenge Group and the chair of Public Health at the University of Edinburgh. And Linda's going to set out the evidence base for nicotine use during pregnancy, financial incentive schemes and relapse prevention. Thank you, Linda. I think you're muted. Can't hear you at the moment, sorry.
Linda, you are unmuted on the screen, which is a bit of a concern. Is it something on your laptop, maybe, that you've muted something on the laptop?
if there isn't anything quickly obvious, perhaps we move to Misha more and then come back to you, Linda. Is that a better plan? And if you can't see anything quickly to...
We'll drop you an email, Linda, with some suggested alternatives.
Is that brilliant? Thank you. Well, we'll come back to you, Linda, and look forward to hearing your presentation. But in the meantime, let's move on to Dr. Misha Moore, who's a National Specialty Advisor for Obstetrics and Public Health at both NHS England and Improvement. And Misha's going to talk about the NHS's contribution to reducing maternal smoking via the long-term plan and the maternity transformation programme. So welcome, Misha, and thank you for being ready and stepping in. That's brilliant.
No problem. Can you hear me, Clea?
I can indeed.
Great. Now I have to work out how to share my slides. Do let me know if you can see them.
Yes, we can see, definitely we can see your slides, so that's good.
Brilliant. Excellent. Thank you for the introduction. Oh, can you see my slides? Because I can't see my slides anymore.
No, we can see, I think probably your desktop and a lovely smiley face.
Right. 1 second. Sorry for this. Let me just try that again.
And while Misha's putting her slides up, just a reminder to everybody, any questions that you might have, please pop them in the chat box or in the questions, and they'll all be put to the ASH staff, who will answer them and then send the answers around in a document to everybody after the event. And apologies that we don't have time during the event to answer the questions, but we will try and make sure that they're all addressed.
John, I don't know if you can hear me, but do you want to share Misha's?
Yeah, that's probably easier, isn't it?
Yeah.
Yeah, okay, do that now. Effie, I'm just going to hand these to you, so.
Brilliant, thank you. So, Misha, can you see your slides now? Misha, are you there?
Having a little technical moment, aren't we?
We are a bit, but
okay, I can see Misha is unmuted, so I'm not really sure why Misha can't talk. Oh dear.
So
John, if we get maybe we could try and see if we can get if you I don't know if you can hear me, so we can't see. I think we might have lost Misha actually. It's gone italicized on the thing, so she might be rejoining potentially. Would you let Linda know how she can join by telephone? We might have to go back to having Linda.
Yep, will do.
I will
I think it's one of these kind of virtual moments where we can welcome Jackie, because I can see Jackie. Jackie, we are in the process of trying to reconnect with Misha and trying to get sound from Linda Bald. So it's one of those moments where we have got different people lined up, but we can't see or hear them at the moment. But welcome and thank you for joining.
You're very welcome.
At the moment, we're inviting different panelists to mute and turn off their cameras until they're speaking. But it's lovely to see you here, and thank you for joining us.
I wonder, Clea, given that we're a bit paused, if Martyn Willmore is still online, there are a few questions that people have posed from his presentation. Perhaps it would be a good opportunity to just take a couple of those. Martyn is still here.
I'll say something and check if you can hear me.
Yeah, no, we can hear you. Great. Well, that's a relief.
Yeah. Hazel,
So,
can you,
yeah, I'll pose some of those questions. So Martyn, we've got a question here that says the evidence to resume carbon monoxide monitoring is strong, but midwives are still very anxious and reluctant. Any suggestions on how to reassure midwives that CA monitoring is not going to compromise their safety?
Yes. So it's easy for me to kind of talk about the evidence that we've built up. I think what we have seen from certain regions and certainly some localities that are places that have really taken a kind of proactive approach to resuming CO monitoring. And I think what we're keen to do, probably working with yourselves, Hazel and Ash and others, is to draw up some case studies around specifically how they've done that. As I alluded to in the presentation, I do totally understand the concerns that have been expressed, but I think the guidance that we've produced, some of the materials, and I know the support that Royal College of Midwives have been producing as well. But I think there's nothing quite like hearing from your peers about how they've overcome some of those challenges. So I think some good case studies, and I know that we've spoken about maybe putting on an event specifically around this in the future too.
Thanks, Martyn. I just while we're there was another question here. Some practical questions around the, what you can use to sanitize the things, but I think those are the sorts of things that we'd want to pick up through case studies, I'm guessing.
Again, I understand the question. There's a lot to talk about whether alcohol wipes are appropriate, and they're still not, because they tend to mess with the internal workings of the CO monitors. I would point people towards the e-learning for health training, which in turn also points people towards specific guidance for the products they use, whether that be bed fonts or MD diagnostics, and that will take them through in some detail how products should be cleaned and what are appropriate cleaning materials to be used.
That sounds like useful advice, as we've got a few people saying there are various kind of queries around alcohol gel, wipes, etc. So that sounds like good practical advice. There's also a question around a standardised risk assessment for carbon monoxide monitoring. Is there any plans to produce anything like that?
I know this is something we've spoken about briefly with the Royal College of Midwives, and certainly at the end of that e-learning for health training program, there is a checklist of sorts which poses a series of questions for localities to think about whether they are following the guidance. And I know I've had some feedback that might not quite kind of fit the bill in terms of a local risk assessment. So if that's something that's preventing places from resuming, then I'm kind of happy to work with those places on developing something.
Thanks, Martyn. And then just one last question, and then Clea, I wonder, as Jacqueline's here and does appear to be able to talk, maybe we might invite Jacqueline to speak, because we seem to have lost all of our other speakers. There was a question here about whether you would advocate stop smoking services outside of maternity restarting carbon monoxide as they're going back to face-to-face intervention.
Again, I would, and again, the principle being, if they're comfortable in resuming face-to-face interventions, then they're already fulfilling a lot of the criteria for a safe environment to conduct CO testing. So presuming they've done IPC assessments around the space that they're working in, the ventilation, and they're comfortable to be sat opposite a client. And that being the case, they really then only need to follow their manufacturer's guidance on how to handle and to clean the equipment safely. So yes, it's an interesting one around the stop smoking services. We really haven't hopefully brought any pressure to bear on them to resume face-to-face support, in part because they've done such a sterling job in continuing to offer support remotely over last year and have been seeing many clients and achieving fantastic quit rates. But yes, where localities are slowly moving back towards face-to-face, then yes, they should also be able to resume CO monitoring too.
Right, Clea, I think we should hand over to Jacqueline. I can see Misha is almost back online, but hopefully she'll be able to speak shortly.
Yeah,
thanks,
thank you. Thank you, Martyn, very much indeed. Jackie, could I ask you, that brilliant, she's there already, I can see. We can't see, yes we can, perfect. So delighted, and although she's further down the agenda, we're pulling you up rapidly, Jackie, and delighted to be able to introduce Jacqueline Dunkley-Bent, who's the Chief Midwifery Officer for England at NHS England, and she's going to set out the NHS's contribution to this agenda. And then Misha, we'll come back to you, if we may, afterwards. So Jackie, over to you.
Thank you so much, Clea, and delighted to be invited to this amazing event. I've got some slides that I think will be shared by one of your colleagues at ASH at some point, but as my slides are being uploaded, it's really heartening to hear some of the previous speakers talk about how we've managed to push through some of the challenges that the pandemic has presented for us and for everybody that's listening today. Just a huge thank you for the contribution that you have made during the last 16 months. It has been a challenge for everybody, and I just want to personally thank you all. For maternity services, we've had some suspensions, we've had challenges in relation to sickness, absence, we've had nurses and midwives that sadly haven't survived, and of course doctors too. And it has been challenging, but we are making strides, and as you can see, the situation that we have now is pretty phenomenal in terms of the vaccination programme. So a huge thank you for everything that you have done in this space. Now I have my slides, we'll go on to the next slide. And I was rather hoping that Misha would have gone first, because I was then going to take my lead from her in terms of what she has and hasn't shared. But this is the situation that we're in now. So that's my thank you to you. And as you can see there, we've suspended services in terms of things like home birth services and such like. But in relation to smoking, the CO monitoring was on pause and is now restarting. And we've heard from the previous speaker the reasons why. So on to the next slide. So we've had a significant contribution to make. I'm not going to go through the detail. We have only got 10 minutes. So we have had a significant contribution to the health of people who use maternity services. So on average, we have 660 births per year in England, and we have a maternity transformation programme that is helping us to transform our services so that England is the safest place in the world to be pregnant, birth and transition into parenthood. So I'm not going to go through the detail. We're 5 years into a 5-year programme, and we're transitioning into the long-term plan now. Next slide, please. So our ambition, other speakers have alluded to this ambition. Misha may well allude to this too, but we have a safety ambition and a personalisation ambition. And of course, as you can see there, this is about reduction in stillbirth, in brain injury, in maternal death, in preterm birth. And the whole personalisation is about not providing care for buildings, but providing care for people, and that's underpinned by the health inequality challenge, because we have a disproportionate we have inequality in health, in maternal health outcomes for communities like in the smoking space, predominantly for the socioeconomically disadvantaged women, and for other inequalities in outcomes related to neonatal death, stillbirth and maternal death. That is really focused in communities that are...
I'll make sure Linda's on next then. Okay, thanks then. Bye.
From Black, Asian, mixed ethnicity backgrounds and socioeconomically disadvantaged women. On to the next slide. So how we're contributing to this agenda in terms of the stop smoking is all of the above. Personalised care that I mentioned will ensure that we have purposeful and meaningful conversations with women who are smoking to help them in terms of stop smoking, immediate stop smoking advice, very brief advice, and then referral on. But as you can see here, our progress towards achieving the safety ambition, we are making strides, and we do know that we have on record today the lowest stillbirth rate ever on record, and that's something to be commended in this space at this time. Things may change once we get through some of or once we are sensitized to the pandemic data, the COVID data, but nonetheless, right now, we are delighted that we are moving in the right direction. We have a long way to go with some of our communities that experience inequality in health outcome, but for the majority, we are moving in the right direction, but we have a long way to go. Reflecting back on my career that spans 30 years, I'm always quite surprised that our pace of change isn't more than what it is. And smoking is the most single most preventable risk factor, and yet our progress has been laboured, but we have a good news story to say about that, and we are making huge strides in stopping smoking, and indeed in the type of person that is continuing to smoke in terms of the socio-economic status. So really good story. We have a long way to go still to meeting the ambition, but this graph shows that we're on trajectory for doing that. Next slide, please. One thing that I really want to major on, I don't think Misha will talk about, is the continuity of carer, and how does the maternity programme contribute to this particular agenda. Well, the continuity of carer is care provided by the same midwife throughout the antenatal, labour and postnatal period. The evidence is compelling. You can see it there for yourselves in terms of improved outcomes and improved experiences, and also improved experiences for the working lives of midwives if the model is implemented properly. But in relation to the smoking space, personalised care, sharing your information with somebody who is known to you, means that you will share accurate information about your smoking status and other factors that are influencing why you are choosing to smoke, or not choosing. It's not a choice for many, it's a crutch, as we know. So the continuity of care will really assist, and is assisting, with supporting women to have those meaningful conversations, to look at the backstory, not just look at the story that's being presented during a consultation, when people are in theory strangers if they haven't gone through that continuity for midwives and for obstetricians. So as you can see there, this is our state of play. We have 1/6 of women that are receiving continuity of care in England today, and our ambition in the long term, in the Better Birth and the long term plan, is that most women will receive continuity of carer. On to the next slide. I'm just going to canter through a little bit faster now because I'm running out of time. So I've mentioned the national ambition, and this is the ambition in the long-term plan. Just majoring on the ambition in the long-term plan, the NHS will accelerate action to achieve 50% reductions in stillbirth, maternal mortality, neonatal mortality and serious brain injury by 2025. On to the next slide. So these are the priorities, and as you can see there, if we focus on bottom left, and that is the implementation of the Saving Babies Lives Care Bundle, and naturally, of course, element 1 is really pertinent for this particular event in relation to the Stop Smoking Challenge. On to the next slide. Mentioned those previously. Saving Babies Lives Care Bundle, the long-term plan is now our live policy. Better Birth has transitioned into this plan. On to the next slide. So very specifically, the Saving Babies Lives Care Bundle, we're all familiar with this element 1, and that is reducing smoking in pregnancy. And our previous speaker spoke about the pause in CO monitoring because of the science around experiences or services that create that increased viral load. So now we have a situation where we are resuming CO monitoring, but during that time, can I just say, during the time when we had suspended using CO monitoring because it was considered to be an aerosol generating procedure, and now we've resumed that for most. In between times, midwives and obstetricians did not stop providing guidance, support and referral for women who shared their smoking status at booking or subsequent antenatal appointments. But nonetheless, we're right back on track. I would still say that we are not 100% there. with the implementation and the dissemination of Saving Babies' Lives Care Bundle, all the elements, but our ambition is to really ask the system, our maternity providers, to implement at pace and to get back on track. Onto the next slide. So my call to action after that whistle stop presentation is really to think back, and I'm going back probably over my career, which is 30 years, thinking back over 30 years and thinking where we were 30 years ago with Stop Smoking, our initiatives, our interventions, our education and training, referral pathways, what women really thought about the advice we gave about smoking and what they didn't think, the ripple effect through their families, and where we are today, a 30-year history. What I will say is that what we do, our contact ripples through generations. Our contribution ripples through generations. Why? Because we know that the environment in the womb is significant in terms of what might happen to that individual when they're middle-aged, younger, or even older in terms of their health potential. And I'm thinking of cardiac disease and smoking. And there are other things that can be attributed to the environment in the womb in terms of the psychological challenges too. So my call to action, based on all of the above, is that we have a 30-year history. We have a long way to go. We have made strides. Yes, we have. But we now want 100% implementation of the Saving Babies' Lives Care Bundle and this single most preventable risk factor for mums who smoke to be reduced, and for the appropriate interventions to be put in place so that we can say we have a smoking rate that is less than the target that we have set ourselves today, less than that. So thank you very much for listening, and hope you found that helpful.
Thank you so much, Jackie. That was really, really helpful. And given that you were put before Misha, and I could see that your presentation was designed to go after hers, I'm really, really grateful that you stepped forward, and a really clear call to action. Thank you very, very much indeed. So reversing things, we're now going to go back to Misha, and then after Misha we'll have a short break. But thank you all very much for bearing with us as we skip around our agenda. And Misha, welcome back. And
thank you. I'm so sorry about that.
No.
Slightly scared of touching anything on my computer, so I wonder if I could ask you to share my slides this time. I sent you just as this was starting, John, or Hazel or Effie. Brilliant, thank you very much. So yes, apologies for that. So thank you for having me. I'm Misha Moore. I'm one of the National Specialty Advisors for Obstetrics with a focus on public health at NHS England and Improvement, and I'm here to talk to you a little bit about the maternity transformation programme, but I'll probably concentrate a little bit on the long-term plan and where NHSE and I are contributing to this agenda there. Next slide, please. So we all have the same slide today. Really, I think we've been so involved in COVID, and it's difficult for us to remember about all the things that we were doing before COVID. So this is just really to remind everyone what other people have said before, the importance of addressing smoking in pregnancy. It's still the #1 modifiable risk factor for poor maternal perinatal outcomes. And again, the statistic at the bottom, which both John and others have shown before, that almost 10% of women just under are smoking at the time of delivery, which is above the national ambition, and there really is more to do in this area. Next slide. So as Jackie has mentioned, Saving Babies' Lives Care Bundle is an area that we have been contributing to in the smoke-free agenda. First published in 2016, it was refreshed in 2019, and on the next slide we again have that element 1, which I'm assuming just by signing up today we have a very engaged audience that hopefully you're all very familiar with this element. And this element really, what it does, it gives practical steps and practical advice for maternity services on how to basically implement NICE guidance on smoking in pregnancy. And it concentrates on three areas really. That identification of women through universal carbon monoxide testing, both at booking appointment and at the 36 weeks antenatal appointment, and that step of opt-out referral to stop smoking specialists and stop specialist support, and also really training for maternity staff around that and use of carbon monoxide testing, and the very important very brief advice that should go along with that. And you know, we've had a lot of success in this area. All providers are now signed up to the Saving Babies Life Care Bundle. In our recent tracker surveys, we found that more than 85% of providers have some quality improvement work going on, specifically around element 1, which is excellent. And we're very good at identifying women who smoke. But I'll just bring you back to John's comment and John's statistic of 16.5% of women actually setting a quit date. I think it's really important for us to remember, particularly in maternity services, where there's this very practical component of this element around CO testing, is that a really key part of the element is the referral to stop smoking services, because that in effect is actually the intervention for the woman, because we know that if you are referred to and uptake stop smoking support, you're 4 times more likely to quit than if you didn't have specialist support. So it's really, really important that we acknowledge that actually one of the most important things is actually getting women to engage with stop smoking services. And I think that's where the long-term plan comes in. Next slide, please. So the long-term plan has prevention as a core component, and what it does, it actually sets out the NHS's contribution to tackling tobacco dependence and this idea of a smoke-free generation. And it's designed to build on what we've got already. So it's designed to build on all the good work that's happening around the Saving Babies Life Care Bundle. It's designed to work synergistically with current stop smoking services, not as a substitute for them. And it has commitments for maternity, but it also has commitments for inpatients and for mental health services. So it's intended to focus on both physical and mental health services. And whilst it has a certain level of national direction, the intention is that it's for, you know, local development and delivery. Next slide, please. So this slide really highlights the relevant bits of the long-term plan around smoking in pregnancy, and the 2 bits are highlighted are here. So as we've heard before, by 2023 to 4, all people admitted to hospital who smoke will be offered NHS-funded tobacco treatment services, and this model is going to be adapted for pregnant women and their partners with a new smoke-free pregnancy pathway, including focused treatments and sessions. So how are we going to support providers to actually achieve the commitments of the long-term plan? Well, as you probably know, there will be funding coming to support this. Next slide, please. And whilst we're very aware of the impact of COVID and the uncertainty around that, we are very, very hopeful, and our intention still is to deliver the full scope of the commitments laid out in the long-term plan. So if you can see on this slide, it says from 2021 to 2, all systems will receive long-term plan transformation allocations. Well, we're in 2021 to 22 now, and we are envisaging that very, very soon those local long-term plan transformation allocations will be announced. And there will be a phased rollout across all ICSs until the end of 2023 to 24. We've recruited early implementer sites, and they do have a head start, although the intention for them to be a bit further along the pathway so that we could have national learning before the rollout to other sites has been curveballed slightly because of COVID. We still will be sharing all the learning from that in future to other sites. So there is learning across the system from those early implementer sites. And something that I just want to draw your attention to, and I'm going to come back to in a minute, is that this is going to be a single allocation to ICSs, so not to local maternity systems, but at ICS level, and it will cover all elements of the long-term plan tobacco commitments. So those 3 elements that I mentioned before: maternity, inpatients, and mental health. Those allocations should increase over time, so there will be an opportunity for greater coverage of service over that phased rollout. But in the short term, systems will need to prioritise services, and I will come back to that. But I'll just tell you a little bit about what we're expecting and what the actual intervention is on the next slide. That we're hoping everyone will deliver within this pathway. So there is a recommended model that we will be sharing with the systems. It's going to be based on NICE guidance and learning from the Greater Manchester smoke-free pregnancy model, which is achieving very good outcomes, but I know that Jane is on the agenda later, so I'll let her talk to you about that. And it's based really on identifying smokers as per Saving Babies' Lives Care Bundle Element 1, and really this offer of intensive support on an opt-out basis, bespoke specialist behavioural advice combined with nicotine replacement therapy and intensive face-to-face follow-up. It is intensive in nature, so that one-to-one stop smoking service specialist appointment ideally should really be happening at the antenatal booking or really very soon after. Really ideally NRT should be at first contact with the antenatal service and maternity care, and that intensive support is envisaged to be weekly for at least 4 weeks with 6 further appointments throughout pregnancy. Next slide. And so I'll just tell you a little bit about delivery. There is flexibility in the delivery, so there's the ability to use different staff groups. The model that is recommended has been modelled on the basis of a band 3 staff member delivering the intervention. There's the ability to commission across organisational boundaries, so that includes using existing local authority services, and obviously there's the ability to expand, accelerate, intensify delivery using local resources where necessary. And again, as I said, the intention is that this is going to be locally developed and delivered. But there are a few considerations that we would want you to bear in mind whilst you're thinking about what you're doing currently and what you're planning. The first is that this really is a unique opportunity. Getting money to support this work is a unique opportunity to both change and develop your current pathway. So that's not just propping up what you're currently doing or adding in bits. It's really looking at your pathway to see whether it's working based on what we know. And, what do we know? Well, we do know, as we've said before, that we haven't seen the change in outcomes in terms of SATOD rates. And we know that most CCGs haven't hit this target of 6%. When we look at that figure of 24 out of 135 CCGs actually hitting the target, we know that most places will need to really consider what they're doing and whether it's working. We know that there's good practice already in the system, and you'll be hearing from Jane later about what's happening in Greater Manchester, and that's why we have a recommended model. It's based on NICE guidance, it's based on things that we know are working and that have been examples of good practice within the system. So really important to look at what you're doing and what you're planning compared to what's working. What bits aren't you doing and how can you improve your services? And again, we know where the gap is. We know about that 16.5% setting a quick date. We know that there is a gap between identifying women who smoke and actually getting them engaged with stop smoking support. So really, we'd urge you to look at that area, to do everything that you can do to make it easier for women, removing those barriers to engagement. That's why we recommend an in-house model, removing the practical barriers for women, but also the administrative and operational ones, so that a woman really feels that this is an essential part of her maternity care. Equally, we highly recommend pathways for nicotine replacement therapy at first contact, really targeting treatment and engagement of women with stop smoking treatment at first contact, because what we also know is that we have to front load efforts to get in early. We don't have the luxury of time in pregnancy when it comes to stop smoking, which is slightly different from stop smoking in other areas, because we know that actually there is evidence that in order to reverse your risk, you need to stop smoking by 15 weeks, and every cigarette is harmful for babies. So we really need to concentrate actions on engaging women right at the start. And the other thing to consider is that whichever way you commission or deliver the model, what's really important is that it becomes a sustainable element of the maternity pathway. And, you know, really with maternity services having commitment and ownership over this. Next slide, please. So, a little bit difficult because people haven't received their allocations yet, and we obviously don't know how much that will be. So it's difficult to know potentially what can be done now, but there are lots of things that can be done now. Just going back to that point that it will be a single allocation to the ICS. There's lots of things going on in maternity at the moment and across the system, especially with COVID pressures and other pressures as well. Lots of work going on around safety in maternity. So it's something, particularly if it's going on at ICS level, that could potentially end up being missed. So really, really important that even now regions and local maternity systems can actually use their influence to ensure that maternity is a core component of ICS plans, making sure that you advocate for your services and that allocations are then used and prioritised according to need. We ourselves will continue to support the 3 early implementer sites and share learning for future sites, and we're here to support everyone and all other sites going forward. And just, you know, a word to say that you don't actually have to start waiting for long-term funding, long-term plan funding. There's already a lot of work going on in the areas. We know that 85% of providers are actually carrying out quality improvement activity around this area. There's lots of good practice already with the system, and you could actually get a head start. We're here to give you advice if needed on that, on whatever you're doing now and when you're planning when the funding comes through. And on the next slide, just to finish, we've got some contact details for you. We've also got a community of practice in our NHS Futures platform, so the details are there, and we're very happy to share that with the ASH team to get across to you all. So thank you very much.
Thank you so much. Really, really helpful. Lots of information, and as you say, no need to wait. Time, you can always get started. So thank you. And with this ever-changing programme, actually, I'm going to suggest that we go straight on to our remaining speakers, partly because Janette and Natalie, I think, have to leave quite soon. And we're not going to have Linda because we can't get her on, but let's move on to Janette Beer and Natalie Wood from the Royal Bournemouth Hospital, who again share the results of a programme of work they did to support vulnerable pregnant smokers to quit. So thank you, Janette and Natalie, and thank you for bearing with us while we go round our different agenda. Over to you.
Lovely. Thanks very much indeed, Clea. Hello, I'm Janette Beer. I'm a Band 3 maternity support worker providing project support to our smoking in pregnancy service.
And I'm Natalie Wood. I'm the Band 3 support worker leading the quality improvement pilot to support the vulnerable women with smoking cessation.
So one of the key aims of this pilot was to improve the proportion of smoke-free pregnancy. Let's go to the next slide.
We're not able to change our slide.
John, can you take control for us?
Yep, sorry, I'll do that now.
Lovely, thank you. It's not going forward for us.
It's okay. Great, you should be good to go now.
Lovely, hopefully you can all see that on there. So one of the key aims of the pilot was to improve the proportion of smoke-free pregnancies amongst our vulnerable pregnant women, and in so doing contribute, as we've already heard this morning, towards the Tobacco Control Plan's target to reduce the prevalence of smoking in pregnancy to 6% or less by next year. So we're defining vulnerable women as those with mental health illnesses, drug and alcohol addictions, those that have where there are safeguarding concerns, and those women who are under the age of 16 years. To support these women through their pregnancies, we have a specialist team called Oasis, which is made up of midwives and maternity support workers. So with support from our management, Carmen Cross, and also Heidi Croucher from Public Health Dorset's Smoking in Pregnancy Project Lead, we embarked on a 12-month quality improvement pilot to improve the engagement and quit rates amongst this group of women. And we did this by training one Oasis maternity support worker, Natalie here, to deliver a 12-week quit programme following the Baby Clear model, which is also known as the Greater Manchester model.
Next slide, thank you.
So why do we need this pilot? Well, when we analysed our data, we identified that the engagement rate for our smoking cessation service when it was provided by a specialist midwife was poor. In fact, only 5.4% of vulnerable women signed up for support. So obviously this needed improving. We also wanted to evaluate if a patient-centred, individualised approach to smoking cessation for vulnerable women would improve their quit rates when compared to the service which is now currently provided by an external smoke stops organisation. And this current service that we have requires women to be 18 years or over, to have the ability and the motivation to actually register for support. It provides no face-to-face contact and only a limited number of consultations. It does not provide a direct supply of nicotine replacement therapy. Instead, women are signposted to local pharmacies. And it actually only provides just a generic approach to motivational text. So there's nothing specific to the women or her situation. Another aim of ours was to assess if a maternity support worker would be effective and have more success in supporting vulnerable women to quit. It was something that we hadn't tried before, so we thought, right, we'll give it a go. Next slide, please. So our pilot design, so to deliver the aims of the pilot, what we firstly needed to do was upskill our support worker, Natalie here, who works within the vulnerable women's team, to deliver a 12-week quit programme following the Baby Clear model. And what this involved her doing was attending a 2-day training course and also had additional shadowing of experienced smoking in pregnancy midwives from our pool site. She also had additional training to enable her to provide a direct supply of combination nicotine replacement therapy, NRT, in a hospital setting. One of the things we also wanted to highlight and look at the design of our pilot was to offer women behavioural support using a wider range of contact methods. For example, home visits, meeting with the women when they were attending their antenatal consultant appointments, as well as telephone and text contact. We know that these women sometimes lead unconventional or chaotic lifestyles, and we felt it was really important to offer some flexibility in the number and the timings of the smoking cessation consultations, as well as the location. Our pilot sample, as it's a quality improvement methodology we were following, we wanted a small sample for Natalie so as not to overwhelm her with her, obviously her homework that she's got to add this new function into it. So she recruited a caseload of 2 newly motivated pregnant smokers per month for a total of 12 months onto a 12-week quit programme. And when she had her consultations with those women, it would she would be obviously giving them counselling, the nicotine replacement therapy, recording their smoking status, and undertaking carbon monoxide testing as well at each of those contacts. So we commenced our pilot, and within a few months, the pandemic hit and obviously impacted on our work.
This impact resulted in periods of inactivity of the pilot, so we decided to extend it by 6 months to make up for the lost time that we'd had. We had to change the way we delivered the service. Due to COVID restrictions, we weren't able to offer any face-to-face appointments or the CO2 monitoring, and all contact was reduced to telephone calls and texts and FaceTime. These COVID restrictions really impacted our engagement rate. Quitting smoking simply wasn't a priority for these women at this time. Like us all, they were faced with a global pandemic which caused increased anxieties and added pressures into their life, such as problems of childcare, working and finances. To help overcome some of these problems, I created educational videos that I sent to the women after our initial consultation appointment. This helped create that connection by putting a face to the name, and although unable to be face-to-face, I was still able to show them how to use their NRT products effectively. One of the positive outcomes from the impact of COVID would be that I'm now able to post NRT directly to the ladies' home addresses, whereas before they would need to collect it from me here at the hospital, which sometimes created a bit of a barrier if there were limits with their travelling. So how successful were we?
Next slide, please.
Our figures showed that 89% of vulnerable women contacted by myself, 16 out of those 18 signed up to the QUIT programme and set a quit date with me, compared to the 5.5% of those referred to a specialist stop smoking midwife. 37.5% of those who set a quit date have successfully quit or are currently progressing well with the programme, compared to the 2 women who set a quit date with a specialist midwife but didn't continue with the programme. 62.5% of recruited women who set a quit date decided not to continue, or were what we call a lost to follow-up. As well as COVID pressures, this included unavoidable reasons such as sadly miscarrying. The ladies that were lost to follow-up were redirected back to their community midwife so their CO testing could be routinely monitored and offers of re-referral to the service could be made. How much is this costing? Well, we've worked out for it to be around £350 for a full 12-week quit programme for one person. This is dependent on travel expenses, obviously where the ladies live, and the nicotine products that they choose to use changes the prices slightly. And that isn't including any training that was put in initially. To expand the pilot, we are hoping to introduce a new personal carbon monoxide monitor called the ICO Quit, which the ladies will be able to use at home, which might be more effective for them.
Next slide, please. So lessons learned. What do we learn from this pilot? Well, our initial findings are that vulnerable women are more likely to engage with the maternity support worker. And possibly, we believe the reason for this is that the support worker has already established that rapport and built trust with these women when performing their other duties within the OASIS team. As mentioned before by Natalie, the pilot confirmed that a support worker is unable to dispense nicotine replacement therapy outside of a hospital setting. However, as part of COVID, as already mentioned, we were actually able to develop new standard operating procedures to post the products once a midwife had checked them as well, double checked them. And this has actually proved really effective and is something that we're likely to actually keep and progress forward with. Before COVID, when we were undertaking the pilot, Natalie proved very effective at delivering the Baby Clear model, and that's the quit rates support that. Performing the carbon monoxide monitoring and also undertaking the counselling side of things. And I think certainly it has to be said that shadowing of our experienced smoking and pregnancy midwives from our pool site was really important in the early phases of the pilot. One of the things we identified was that Natalie was shown how to communicate the medical terminology for the NRT exclusions and the criteria, and was able to then relay this information in a way that could be understood by the women. So that proved really early on when we were looking and reviewing, as we do with the PDSA cycle of the quality improvement methodology, to do those little checks all the way along to see what was working and what wasn't. And it previously discussed, obviously COVID did affect the way we designed the pilot as well as the outcomes.
Next slide, thank you.
So in summary, overall, how do we feel we've done? Well, I think probably everyone would agree under quite challenging circumstances to try and undertake a pilot in those circumstances. It has provided us with encouraging, albeit limited, evidence that the introduction of a specialist maternity support worker offering behavioural and NRT support does improve engagement, and I think the 89% engagement rate supports that, as well as the quit outcomes as well, 37.5%. We believe that the patient-centred approach and flexibility of the service offered by Natalie did contribute towards those positive outcomes of the pilot. And certainly, I think one of the things is maternity support workers are often an untapped resource, and we were able to develop this new role, which Natalie has certainly embraced, developing new skills and expanding her knowledge of smoking in pregnancy exponentially. There is a potential, hopefully, for this role to be incorporated permanently into the OASIS team. The pilot highlighted, as we've mentioned before, again, the unregistered practitioner dispensing the NRT, but again, we've already talked about the solutions that we've put in place and that they've proved effective. So finally, our future aims for this pilot, we're hoping we can extend the pilot to incorporate a larger sample of women to truly assess the effectiveness of employing a specialist at MSW to improve the number of smoke-free pregnancies amongst vulnerable women and contribute, obviously, to our target of the 6% national ambition.
Next slide. Thank you. Thanks for listening.
Thank you so much, Janette and Natalie. Really, really inspiring. What amazing outcomes, and just lovely to hear how you managed to navigate through COVID as well.
Thank you.
And do remember to keep putting questions, everybody, in the box. I can see lots of people are, and we'll make sure that they're all answered and sent out to you. So we've got one remaining speaker that we're going to go on to Jane in a second, and then after that a short break, and then straight into the regional sessions. So it gives me great pleasure to introduce our next speaker, Jane Coyne, the strategic lead for the Making Smoking History and the Smoke-Free Pregnancy Programmes in Greater Manchester, and she's going to talk about the Greater Manchester Smoke-Free Pregnancy Pathway. Jane, over to you.
Oh, thank you so much, Clea, and thank you very much for asking me to come and speak today about the GM model. John, are you going to do my slides? Brilliant, thank you. You got to the first one. I think what's really important is everything we've heard today is that smoking in pregnancy remains a key public health concern and remains a single most modifiable risk factor for adverse outcomes in pregnancy. As a midwife myself of 20 years, I think we can see that the death of a baby has significant psychological, social and economic consequences for parents and their families, which may persist for many years, and that ripple effect of losing a baby, you know, can go right through a whole family. So it's really important to know that it's not just the woman, it's around everybody around her that this is affecting at the same time. Thanks, John. So this is us in GM. It's nice and colourful, and obviously just to show you that we cover 10 local authority and CCG areas. We've got 7 maternity providers within that, with Manchester providing one of our biggest tertiary units in the country with approximately 12,000 births a year, with Tameside and Stockport being some of our smaller ones with about 2,000 births. So a lot of our teams obviously have to work cross-boundary because many of our women will not birth in the same places where they choose to live. They choose to live. Thank you. So what did we do for the GM programme? We got about 1.8 million given to us for a 2-year project because we knew that our smoking at time of delivery rates were not really where we wanted to be. When I started the programme in 2016-17, our rates were about 12.8. In GEM we're slightly different, that we're a devolved region, so we get our health and social care budget given to us and are really allowed to decide how we spend that. So we decided that we would put a coherent smoke-free pregnancy programme in that would really invest in our workforce, provide equipment and targeted intervention for those who smoke during pregnancy. So our first investment in our workforce, that we utilised the Baby Clear model designed by Hilary Waring and IPIP, and that's an evidence-based approach to systematise and embed organisational change in line with NICE guidance and the Saving Babies' Lives recommendation, where we introduced standardised very brief advice and carbon monoxide testing, and obviously referral into stop smoking services. We included a unit risk perception intervention, so that's a really hard-hitting motivational interview for those who are still smoking at the booking scan, to encourage engagement with stop smoking services and really giving a more harder hitting intervention that's a little bit more deeper than VBA. And running alongside that, we had a smoke-free pregnancy incentive scheme for those who would find it hardest to quit without additional support. And obviously this has been kind of helped us during COVID as well. In part, that levelling up is that women have not only saved their incentives for something nice for themselves, they've actually been spending them on food, heating, you know, it's kind of those activities of daily living. So we've kind of felt like they've been a bit of a lifeline for some of our women during this period as well. Thank you. So what have we done? We obviously introduced Baby Clea, which gave us a really clear model and pathway for introduction of carbon monoxide monitoring. And just to remember that carbon monoxide monitoring is not a lie detector test. This is something for all women around the risk of poisoning from carbon monoxide. We've made it a holistic offer, so we're offering that for every woman at all antenatal contacts and admission to hospital where appropriate as well, to really encourage the working with a long-term plan model to prevent abstinence while women are in hospital, but to really give us any opportunity where we could provide a really good, very brief advice discussion for midwives. And I think what's been really important for me is that the level of investment we've put in our midwifery colleagues. I think those midwives on the front line who are seeing those women for the first time at a booking, it's really important that they understand their role in kind of promoting the rest of the smoke-free pathway for a woman. What they say is absolutely pertinent to how women engage with the service after that, and that they're absolutely key in kind of motivating those women to think about quitting. And from that, the midwives decided to kind of really add that impetus, is that they wanted to make a telephone referral. So they wanted to pick up the phone directly when they were sat with the woman and make that referral, just like we would if somebody had reduced movements or they were bleeding or they had any other medical concern that we might want a review for. And that was absolutely key in the women kind of seeing that engagement with the services, because we saw it as important. They said, well, if the midwife's going to do something about this, this is absolutely key and I'm going to attend. So we saw kind of roughly levels of engagement around about 25% when we started. When the telephone referral started, we saw upwards of like 85%. So we really saw that lever of women knowing that the midwife was that proactively doing something there and then. I think what we gained from behavioural insights as well is that those who are more likely to be given an appointment are more likely to attend it. And the appointment, like I say, being made there and then. Some of our providers also do an electronic referral as kind of a backup to give them that surety that those women are being attended. So that's really good as well. When we started, we put 13 maternity support workers into the system, and I think the feel was that they would work alongside, oh, can we go back, John? Sorry, specialist maternity support workers within the system. And the aim was for those areas who had a traditional stop smoking service that they would kind of work alongside them and begin to see the pregnant smokers. What we found was in 2 areas where the service had been decommissioned, we put actually specialist maternity stop smoking teams in. And this meant the women were only being seen by a specialist midwife and MSW team specifically trained in tobacco addiction. And what we did see was really vast differences in engagement, quit rates. I think some of our maternity services were seeing quit rates of upwards of 80%, really not seen anywhere globally as well. And I think, as Misha mentioned before, you know, the women see them in a uniform, they see them as part of the care, they feel like they're getting that holistic offer. They know that the MSW will see the midwife and they've got that engagement. We share the same record, which is, you know, it really increases efficiency, and I think it increases confidence and trust in the women in the services that are being offered rather than going to an external service. Obviously, risk perception for those who didn't engage by the first contact. We know that with some women, you know, it might have been 20, 30 times they've been quitting, or they might have been to us before and not been able to quit. So we obviously introduced the risk perception, that motivational interview that occurs after the booking scan. It's an optimum time as women have just seen the baby on the scan. You know, they may be motivated to change those risky behaviours. It's a really intense intervention that we hope will pick up about another 50% of women who haven't engaged with us. Running alongside this, our specialist maternity stop smoking services offer an incentive scheme, and this enhanced support throughout really has been a hook that's allowed women to come in and engage with us, and really nominal amounts as well, so about £10 a week for the first 4 weeks and £20 a month up until birth, which has been fantastic, and really seeing that coming through. And probably about 75% of those who engage with us actually remain quit to birth, so that's some really good, I suppose, evidence towards the use of incentives running alongside this. Data analysis, I can come on to that a bit further down if that's okay, John. Examples of our pathway: consistent and standardised approach, obviously CO testing, increased engagement, reducing the cost of complicated births, reducing the number of babies requiring neonatal care, and increasing the family in that as well. And just to say, we have done a brief impact audit in GM, and I think some of the financial implications on 4 price points was about £15 million saving in GM on 4 price points for increasing engagement from smokers into our maternity stop smoking services. So there is some significant economic benefits to this as well. Thanks, John. Just a quick glance at our SATOD just shows you our journey. You know, it's working really well. We're reducing kind of smoking at time of delivery rates quicker than England, but it does take time. It took us a year to implement the programme, and I'm just eagerly awaiting Q4 now to see if we've had another drop in this last quarter and see what our annual is. But it's good to see us heading in that right direction after such a long time. Thank you. And obviously, just because lots of people have asked me about evidence around why we would use that maternity model that we now have across the whole system. So all our maternity patients now are seen by GM maternity-led stop smoking services. We saw such significant quit rates. I think our overall quit rate at the moment for GM is about 54%. Obviously, double the national average, and you can see from the bottom graph there is that we're seeing significant numbers with our smoke-free pregnancy teams compared to those women being seen in existing local authority stop smoking services. Thanks, John. Adapted for COVID, obviously as everybody else has done, we've had virtual appointments, but our main thing was we introduced the individual carbon monoxide monitors, which I think obviously the people around the country have been adopted. And it's just to say that obviously they really help women to support their quit, but obviously the main thing that would made the difference was the maternity support workers. And we've also introduced a carbon monoxide tool through our QI work, just to really show that how we can engage midwives in delivery of CO at each contact. Thank you. Data solution, I think obviously everything I seem to go to depends on data, and I suppose this shows the proof of the pudding of what we need to do. So we work with our innovation agency to develop a smoke-free pregnancy platform, which is kind of one-off record keeping. It works across all my 7 hospitals. We provided their own laptops so they can all access each other's calendars. So if hospital to hospital can obviously they can book in different trusts, you know, sites if the one lives in a different geography to where she's booking, performance manage the KPIs, performance manage advisors, understand what the service is doing. It sends out motivational messages, obviously a platform for virtual appointments, and is really helping us with data collection to identify our issues and barriers. So thank you. What makes it work? To be really quick, a whole system approach. I think today obviously in GM we've got a really comprehensive tobacco control policy that sits around this and strategy, so we're kind of working on stopping women to try and come into pregnancy smoking. But I think once they get to this, it's everybody's job to make sure that women stop smoking regardless of where you work within maternity services. You need really good leadership. I think we need a specialist midwife in every trust to be leading this, working full time. This is my job full time, plus I have 9 specialist stop smoking midwives, and obviously all the work we've undertaken in GM is not an easy feat. We need the bodies within that. Commissioner champions, smoke-free pregnancy champions, as specialist midwives can't deliver this on their own. Obviously utilising data, engaging staff, and most importantly is kind of really excellent, very brief advice. Thanks, John. Lovely, thank you so much.
Thank you, Jane. Just inspiring hearing what you've been doing, and just to reassure everybody that you'll get all of the slides, so have time to look and think about all the wonderful things that you've heard. And we will include in that the slides from Linda, who wasn't able to kind of join us properly. So all of that will be with you, and the answers to the questions. All remains for me to thank all of our speakers and all of you for bearing with us while we've moved around the agenda, covered everything except Linda, but in a different order. And I hope feel inspired to go back and to get back on track and get Saving Babies' Lives Care Bundle version 2 out there and running. So now we're going to move to the separate workshops through the links and the regional breakout sessions that are on your agenda. If you can make your way to them almost straight away, we seem to have kind of not got to the window I'd hoped for a break, but obviously if you need to kind of stand and stretch in between, that's great. But just a massive thank you from me to all of you for showing your commitment by attending today, and hope you enjoy your regional sessions. Thank you. Bye bye.